We herein describe fluorescence guided laparoscopic lateral pelvic node dissection for carcinoma rectum. Lateral pelvic lymph node dissection is technically challenging because of unfamiliar territory and complex vascular anatomy. The surgery can be made easier by visualizing the pelvic side wall as a 3D compartment. With the help of a 3D model, we will describe three planes which will divide the pelvic side wall into two pyramidal compartments. The first plane is the medial plane, which is the uretero-hypogastric nerve fascia. The structures lying in the plane are urinary bladder, the hypogastric and splanchnic nerves, ureter, and the connection to the TME on the medial aspect. The structures which traverse through the plane are the superior and inferior vesical arteries. The second plane consists of extrailiac vessels, psoas muscle, and the obturator internus. The other structures which traverse through the plane are the internopudendal artery, obturator vessels, and nerve, which lead to the obturator foramen. The third plane in the middle is the vesico-hypogastric plane. Here we have the internal iliac vessels, obliterated umbilical artery, internal pudendal artery that leads to Alcock's canal. Our patient is a 44-year-old lady with history of bleed per rectum for 2 months. Colonoscopy showed an ulceroprophytic growth 3 cm from the anal verge. MRI showed a T3N2A lesion in the lower third rectum with a 12 mm right internal iliac lymph node. Patient received NACRT, followed which the MRI showed a residual lower third growth with a right internal iliac lymph node of 7 mm. Patient was planned for laparoscopic low anterior section with right lateral pelvic lymph node dissection. ICG was instilled around the tumor at the beginning of the procedure. Having completed the rectal mobilization, the template for pelvic lymph node dissection was approached. With the assistant giving continuous traction, the round ligament was scored. The dissection starts at the external iliac vessels. The dissection is carried forward medializing the ureter. Ureter is dissected cranially till it crosses over the external iliac artery, which forms the superior limit of the dissection. Anteriorly, it is dissected till it crosses under the uterine artery. The next step was the dissection of the uretero-hypogastric fascia, which envelops the ureter, hypogastric nerves, and the pelvic splanchnic nerves. The dissection then continues over the medial aspect of the external iliac artery. Staying a plane just above the adventitia ensures completeness of lymph node clearance and avoids injury to the vessels. The dissection then proceeds along the medial aspect of the external iliac vein. After the dissection of the external iliac vein, we can identify the internal obturator muscle. The distal part of the obturator nerve can be visualized. The next step is the dissection of the vesico-hypogastric fascia, which surrounds the internal iliac vessels, the inferior and the superior vesical arteries. Dissection then proceeds along the lateral and the medial obturator group of lymph nodes. The next step is the dissection of the internal iliac group of lymph nodes. We dissect the proximal part of the internal iliac artery and continue along the internal pudendal artery. The branches of the internal iliac artery are safely clipped. Dissecting along the interiliac artery, the obturator artery is identified and clipped safely to avoid any bleeding deep in the pelvis. At this juncture, we can visualize the lumbosacral trunk and the internopudendal artery entering the greater sciatic notch. Unlike for other pelvic malignancies, lymphnodal clearance for rectal cancer goes below and beyond the nerve deep in the pelvis for adequate lymphnodal clearance. The inferior vesical group form one of the most common sites of recurrence after suboptimal pelvic lymph node dissection. Care must be taken to remove this group of lymph nodes meticulously. For a thorough clearance around the inferior vesical artery, it can be safely ligated without compromising the bladder vascularity. The ICG mode was frequently used to identify the location of this lymph node. This increases the lymph nodal yield and ensures completeness of dissection. The internal pudendal artery was safely clipped and divided. After lateral pelvic nodal dissection, we can identify the skeletonized ureter, the internal and the external iliac vessels, and the obturator nerve. The final histopathology report shows a moderately differentiated adenocarcinoma with a final stage of YPT3N2A with a positive internal iliac group of lymph node.